good. Yes, very good.
Thank you, Greg. I think we should meet more often, so we make less of these introduction errors.
It's one of those tortures that I have to do, and I never get it right.
Anyway, thank you for the invitation. The job given to me was to overview pediatric liver transplant. It's a big topic, so I would be basically touching the surface. And yes, I would be available for in-depth questions. I don't have any commercial relationship. What we want to achieve today is to learn about the current indications as well the medical concepts that shape our decision-making process when we take care of these patients with liver disease, to learn about the logistics of listing a patient and what kind of decision-making goes in or in the evaluation process, indication, contraindications, and then post-transplant care. How is it different from adults? There could not be a better time for me to do this talk. We are really in celebratory mood. With the very first liver transplant just done 3 weeks ago, after almost 2 or 3 years of hard work, a lot of people here participated, engaged in our planning process, in finally listing process, good donor selection, optimization care of this patient before he went in for transplant, and a very successful outcome with our surgeon, perfect surgery, good recovery, and out of hospital in 2 weeks. So there can't be a better time to talk about this issue and refresh our knowledge base about this. And of course, it's a great teamwork. Not everybody who participated is in this photo, so I personally want to thank everybody who participated, and that could be UTHESCA partner, that could be UHS partner, who was engaged, and then we have this proud moment to celebrate. Just to give you a flavor, what kind of patients end up listed, the next couple of photos are type of patients currently listed with us. Biliary atresia is by far the commonest indication. Not only for us, that's true for any pediatric program in USA. More than half of the patients currently transplanted, liver transplanted in USA have that indication. Not so common, but genetic cholestasis, Alagille syndrome, progressive familial intrahepatic cholestasis, MDR3 deficiency, et cetera, is another group. Somewhat different than what adult liver transplant team would see as an indication. And then the metabolic diseases, most of them do present in pediatric age group. Rare ones, hemochromatosis, maybe for the adults, but Wilson disease, glycogen, anything you can think of. And there is a diverse group that meets the indication. And we'll go through when is the right time to do the transplant in these patients. So that's what we will talk about. What are the conditions that lead to liver transplant, the logistic part, the post-transplant care. Almost 25 years ago, when I did my fellowship in Chicago, I learned from my mentor that liver disease manifestation is not limited to liver. You can see these are twins. One has liver disease, one does not. Very easy to identify who's the sick one. But if you do the transplant in a timely fashion, good post-operative care, it becomes very hard to figure out who actually had that transplant. So same set of twins. Show me a raise of hands who thinks this one had a transplant. Nobody? All right. How many thinks this one? If I do elimination process, looks like you all were in favor of this one, but not everybody raised the hand anyway. Actually, this is the one who got the transplant. And the message here is, if you do a liver transplant in a timely fashion, you can reverse a lot of the problems you see when they are presenting with the end-stage liver disease. But yes, the key is it is a team approach. It is very kind of taking care of a fragile patient. So a lot of expertise is needed from many different disciplines put together in a coordinated fashion. Going through history, the very first liver transplant, proof of principle, unlike a lot of other things which happen in adult world first, was in pediatric world. Dr. Starzl was able to extend life of 3 kids with hepatoblastoma who were doomed to die, and that led to the opening of this world. Since then, 1967, it has become standard of care for many different indications that now if I want to put them on a piece of paper, it would be hard to put on a single piece of paper. This is something from my presentation, a publication. And the way I look at these indications are 4 different groups. I think the first group is where you lose liver function either slowly over time, chronic liver disease, and biliary atresia, the topmost indication, or acutely, when they present with acute liver failure and a lot of possibilities. Then there are indications for pediatric liver transplantation where you really are not losing the liver function. So patient may not be jaundiced. And those are either some kind of tumor or infiltration into the liver, or where liver is providing an essential vital protein manufacturing role for the rest of the body. So it could be a clotting factor, anti-clotting factor, or familial hypercholesterolemia where the cholesterol is not metabolized, hyperoxaluria where they need kidney if they don't metabolize that right, and often they need liver together with it. So we'll go these 4 groups one by one to some detail out about it. Progressive liver disease leading to end-stage liver disease is the commonest indication. And in that, I think it makes sense to talk about biliary atresia because that is the commonest indication. What we understand about it now that it is a destructive inflammatory process that affects variable lengths of the biliary tract, almost always the extrahepatic biliary tract, but to see various extents, sometimes intrahepatic biliary tree too. It's not that common, 1 in 10,000 or so. Personally, I have not seen a family with 2 kids of biliary atresia. So we don't think genetics play a big role, but now we have better understanding, which I will share. I think it's probably put together 2 different phenotypes. What is considered the common type, perinatal, is an isolated defect in a healthy term newborn, and that kind of is fool us when the baby is born. It's a healthy term newborn. Everybody is celebrating, and little bit of jaundice is expected, and that often delays the diagnosis. What causes it? There's much better understanding. The animal model is rhesus rotavirus mouse animal model to shed lights on the pathogenesis. The other phenotype, the prenatal type, less common, maybe about 20%, maybe have a different pathogenesis because they often have other congenital malformation, most commonly splenic malformation, but they can have situs inversus. I've seen kids with tetralogy of Fallot's. We had kids with vascular septal defect and needed major heart surgery too. This is the animal model of the perinatal kind. If you inoculate RRV, rhesus rotavirus, at birth to this mice, you can see the acholic stool by 7th day. Courtesy Dr. Jaime Achartea, his mentor, who provided this slide. This is just to show the splenic malformation, multiple spleen in a patient with the biliary atresia splenic malformation syndrome. Both phenotypes more or less present the same way in terms of liver disease. They will have direct hyperbilirubinemia, impaired liver functions, and the diagnostic workup usually starts with the easiest to more risky procedures. Ultrasound, HIDA scan, liver biopsy, but the final test sometimes is intraoperative cholangiogram. Liver biopsy, Dr. Stark is here. A lot of bile ductular proliferation is the hallmark, very specific, but not 100% there. So in a rare ambiguous case, we may want surgeons to go in and do an intraoperative cholangiogram to show that, yes, the extrahepatic bile ducts are obstructed and not flowing. Once it is diagnosed, either at the same time when they are doing intraoperative cholangiogram or soon after liver biopsy diagnosis is established, the very first procedure offered is hepatoportoenterostomy, where the ducts are not draining, so you bring a loop of bowel to drain the bile from the liver. This does reestablish some bile flow, but even with this procedure, lot many eventually, so by age 20, some 80% will still need liver transplant. And if we do it in a timely fashion, then I guess there is a lot more jaundice-free time period post Kasai procedure. If you do it less than 8 weeks versus more than 12 weeks, you have a different outcomes. This paper from St. Louis showing that just 20 days delay in the diagnosis, and that's the problem with these patients because they are looking good at birth. So often the jaundice is not, brings that sense of urgency to the caring pediatrician. And many times these patients are still diagnosed late, referred late. By the time they see us, they had the Kasai, but they also have end-stage liver disease. The liver is already cirrhotic. At that stage of game, as a medical doctor, I can support as much as the nutrition. We can use some choleretics. We can control, we can reverse some of the fat-soluble deficiencies, bile cholestasis complication. But the real answer in these patients is eventually liver transplantation. The next group, acute liver failure. Now, this group, when they present with that, usually it's kind of Friday evening presentation. That's what I see two things happening together where when these present, there are a lot of things you want to achieve, but very hard to achieve that in the short period. So these are very challenging patients. I have sleepless night when I have to take care of one of these patients because you want to figure out the etiology. And there are so many possible causes, and half of the time, despite the best workup, you may not be able to figure out the cause. And you want to see if you can find a cause that you can reverse with medical therapy. So a metabolic cause, fatty acid oxidation defect. If you are lucky, this was a overdose of Tylenol. Then there are some ways to correct or reverse the process with N-acetylcysteine. Then you may provide a rescue. But most of the time, that's not the case. These patients don't have a cause that we can identify or we can identify that's reversible in a timely fashion. So they become transplant candidate, right, the time they hit you. At the same time, you are taking care of all the complications. When the liver fails, we don't have good dialysis equipment to take care of that patient long enough. So we have very short window in which we want to get the financial clearance, get the evaluation, and get the patient listed, while taking care of the patient who is having many vital organs involved, the brain, the kidneys, the lungs, with the failed liver. The group 3 is where there is some invasive process to the liver, either benign or malignant liver tumors. The one which is most often seen is the indication and is kind of a prototype how we approach other patients with the liver tumors is the hepatoblastoma. And in this, when we see these patients, instead of T&M classification system, we go for what is pretext. So before any treatment is delivered, a imaging study and alpha-fetoprotein is done to see whether this is completely resectable or not. And if you are in a stage 1 or 2, most of the time it's completely resectable. A rare patient, a patient we just had, we were able to resect, and we are so far following up that patient has not had a recurrence. They do go through some chemotherapy before the resection and after resection. But yes, when it has invaded that you can't resect it in a safe manner, liver transplant is indicated. This is a patient I took care in Dallas. Now he's coming back to see us here, almost a teenager, who presented with hepatoblastoma. And there are certain things about hepatoblastoma that do not meet the dogma. Even if you have lung metastasis like this patient, if you can resect it, you can still offer liver transplant. This particular patient also had the tumor invading the hepatic vein all the way to right atrium, so it was taken care at the time of transplant with chemotherapy post-transplant, and he did fine. Metabolic disease is a very diverse group, so I'm going to just cherry pick few things, not everything possible in 1 hour, where we think we may be seeing this patient. Of course, we have this girl listed with us who presented with the glycogen storage disease, born in San Antonio, diagnosed in San Antonio, but over time had a lot of quality of life issues with the therapy, what is recommended for these patients. So it's a rare indication. The indication evolved with time. So now prevention of hepatocellular carcinoma, once they develop hepatic adenoma, is the leading reason why they need to be listed. In past, when we had poor understanding, often these kids had poor metabolic control, quality of life, that was the indication. First transplant was done 1982 to show the proof of principle. The problem with glycogen storage disease is that you can pack the liver with glycogen, but when the the starvation time, you want to use it, it does not get metabolized into glucose. So you keep packing the liver cells getting injured, but you develop hypoglycemia the moment you get starvation. That compounds the problem. To avoid that hypoglycemia, often they are put on cornstarch, uncooked, or continuous nighttime feed, which is what this girl was getting, and that after an event where the G-tube had a major complication, they decided to take that out. And of course, now she has a hepatic adenoma, so meeting the indication. It's still a rare indication. Just looking at the meta-analysis in 2012, globally, less than 100 patients transplanted for this indication. Type 1A, which is what this girl has, right now meets this indication because she did show on imaging study a hepatic adenoma, but various reasons in this group of patients to feel that the transplant is a choice. When I was in Miami, alpha-1 antitrypsin, I used to see good number of patients. It seems that it is very common in Iberian population, the Spain, Portugal, ancestry, and Sweden. And I think there are a lot of Cuban Americans. So this is a family I took care. All 3 boys have alpha-1 antitrypsin ZZ phenotype. This one had liver transplant. This one had just mild hepatitis. This one normal liver, just to show you different phenotype with the same genetic problem. It is fairly common problem in general population. Second, in terms of gene prevalence after cystic fibrosis. But unlike cystic fibrosis, not all ZZ phenotype will present with the liver disease. Only 10–15% do. So that's why we don't see alpha-1 antitrypsin clinics. We do have cystic fibrosis clinic in various programs. And that's what this family shows, how diverse the phenotypic presentation could be. So far, there is no medical cure. There is a study in Pittsburgh trying to use carbamazepine, but once they develop end-stage liver disease, liver transplant is the answer. Over last decade or so, I think I've started to see more and more of these genetic cholestasis, where either they have type 1, type 2, 3. A rare patient of cystic fibrosis is having end-stage liver disease where transplant may be indicated, but most patients with cystic fibrosis I'm following in my clinic have compensated cirrhosis, and they do quite well. And there is always an issue when you do transplant immunosuppression, would you make the lung worse? So it's a difficult call in this patient, but so far I have not yet to face that decision in the population I'm caring right now. For certain diseases, it used to be a common indication, but landscape changed once we came up with the medication. Anti-BC initially for compassionate use, now available to block proximally so you don't develop toxic metabolites. So tyrosinemia nowadays, the indication for liver transplant is a very rare patient who, despite best medical therapy, developed a hepatic adenoma. Girl we transplanted in Dallas, very high cholesterol, like in 5,000, heart disease, needed heart transplant, and we knew the new heart will not survive till we change the liver because the cholesterol is metabolized in the liver. Another girl we transplanted in Dallas, Budd-Chiari syndrome presentation due to hypercoagulable disease due to primary protein C deficiency, which is made by the liver. So changing liver not only took care of Budd-Chiari, but also corrected the underlying defect she had. Mitochondrial disease has been the indication when they present with liver failure, but we learned over time that we have to be very cautious approaching these patients. Personally, I made that mistake in Miami. We transplanted a boy presented with sodium valproate liver failure. Soon after, we realized liver graft is working, but the rest of the body is just falling apart, the brain, the heart, and the lungs, because we could not correct the mitochondrial defect in other parts of the body, of course. There is also a case I took care here in San Antonio who presented with liver failure, met all the indication for liver transplant, went to Texas Children's Hospital, got listed, but then patient started to improve on her own, and mom made the decision to come back, and now patient has been doing fine. So there is a rare case, and that's what this shows, that there is ontogenic improvement in a rare patient that you have to be also be watching. The one patient we just had recently in last 1 month we think is a mitochondrial disease with the Huttenlocher-Elper syndrome, who had seizure disorder, was doing reasonably okay from the liver perspective, got sodium valproate, and then 2 weeks later presented with liver failure. So very classical story, just waiting for genetic confirmation. But that patient didn't make it, and learning from my past, I was very cautious not going for liver transplant in that particular patient. Let's talk about logistics. When we are confronted with these patients, depending on the situation, our projection, how long this liver can last, we trigger the evaluation process. Could be very urgent in a liver failure, it could be inpatient, outpatient, but almost always involves a lot of team members. From nutrition perspective, social perspective, the financial perspective, because it's not one simple surgery. You need pharmacy to help you out, and thankfully I have a great team to work with. What we do in the evaluation, we make sure the labeled cause or the referred cause is right, and yes, patient meets the indication and there is no obvious contraindication. Some of the contraindications are listed here. Immunosuppression is what separates this group of patients from in terms of surgery. So any active infection would be contraindication. Although HIV is listed, yes, there are some cases done now where, yes, antiretroviral drug therapy are available, that it is possible. But if you have progressive disease of any other vital organ, poor psychosocial support or financial issues or poor compliance in the past, then we may not proceed with the listing. If they are decided to list for a chronic liver disease, similar to MELD scoring system, we have what is called PELD scoring system, pediatric end-stage liver disease. And that came from the SPLIT database, which is studies of pediatric liver transplantation, to look at the mortality risk based on what factors can you predict. And the higher the mortality risk in 3 months, higher your PELD score is. And that's what ranking, the ranking is generated based on that, based on the final rule DHHS wants us to follow. Just giving you that equation, the PELD score, age, albumin, bilirubin, total bilirubin, not direct bilirubin, growth failure, INR, those are the factors, variables. Although we like to use this, and this is the format we have to use, there are so many exceptions to the rule. Currently, every patient we have listed, we have to ask for exceptional points because we believe the patient has higher risk of mortality than what is calculated out based on the fact. And yes, in USA, most pediatric programs, about more than half of the patients they list, they would be looking for exception points. Having said that, this is what we have right now to give you some kind of disciplined approach to this. Acute liver failure patients do not follow the PELD scoring system. They are listed way above the chronic liver disease patients as status 1A or 1B, depending on acute or chronic. You all know that there are 11 regions. We fall in region 4. There are only 3 pediatric liver transplant programs in state of Texas, Houston, Dallas, and San Antonio. So we not only have to serve our immediate community, we probably are expected to serve a large community from Valley area, El Paso. And yes, we are ready for that challenge, and we go there often. And with Dr. Cigaro's help, now we have started to go to El Paso and Valley more frequently. Just the concept about surgery, I'm not a surgeon, and there are 8 functional segments of the liver. Most infants would be getting very far left part of the liver, segment 2 and 3, but other combinations are possible. Unlike adults, where sometimes you can do duct-to-duct anastomosis, that's almost rare in pediatric because a lot of our patients have biliary atresia, already had Roux-en-Y, or the duct is too small. So as you can see, the Roux-en-Y would be most of the patients, unlike adults. One big challenge we have, and that's more for our surgeons, is trying to fit a liver in that small size baby. Thankfully, we have very gifted surgeons who have done it all. They can do splits, they can do reduce, they can do whole size. So our current approach, and correct me, Dr. Cigaro, if I misspeak here, our current approach is less than 10 kilogram kid or a 1-year-old kid. We would prefer a cadaveric segment 2 and 3 because of the large size artery and ability to fit in. That could be either a reduced liver or a split. The patient I just showed had a split liver transplant where the leftover liver was given to an adult. So it's really double advantage. For an older size kid, 3-year, 5-year metabolic disease, maybe a cadaveric size matched whole liver be a better option. We have program capability to do the live donor, but we are cautious about it. You want to add anything, Dr. Sigaro?
I think, it's not reviewed the literature, just my own personal experience. I'd be very nervous with donors who are less than 50 grams, and the literature seems to prove that.
Hepatic artery thrombosis rate in most of these small donors is high. It's statistically significant. So I favor a split or reduced size liver transplant, on patients who are that late.
Mm-hmm.
As we move close. So that's just kind of my personal perspective. I think that's an agreement for me. And at the end of the day, it's really being very, very meticulous in the donor selection of these patients.
Thank you. Few pictures, donor liver, how it looks, back table operation to make it right. Once the new liver is in and it's working, you can see the salmon pink color, the ABGs, bile flowing, normalization of sugars, etc., give you early indication is working. And then patient goes to the ICU. And that's where a lot of handover has to happen. So details about the graft, this kind of anastomosis, the intake, output of various fluids, the blood products used, all those details are passed on from the anesthesia and surgical team to intensivist. One big difference in this group of patients, unlike any other complex surgery, is the need for immunosuppression. This just shows various options we have. Our program currently would be using more of tacrolimus and steroids. Cellcept, azathioprine may be a choice in older kids. We are not using sirolimus as induction, but down the road, if they have renal complications, and I have few patients, I have to transition them to sirolimus. The immediate postoperative care is to make sure the graft is working, the patient is recovering and able to get off the ventilator, and then you start monitoring for infections, because biggest difference, as I said, is immunosuppression, and that changes the outcome. Actually, the mortality nowadays is more due to infection than due to the rejection of the graft. So we are very cautious in these small patients. Small doses changes can make the levels fluctuate a lot. So we often involve our pharmacist in decision making. Early in the PICU, for a month or so, you can see all kind of potential surgical complications. The nosocomial infections can set you back. Over time, the CMV, EBV start to replicate, and 1 to 6 months or so, often they present in that window. Down the road, EBV uncontrolled will lead to PTLD. And that's something different than the adult population. Most adults had seen EBV, so they are not EBV naive going into transplant. Even if they get EBV positive liver, and most of the time they do, it's EBV into EBV. The risk of PTLD is not that high. Our patient, the one who just got transplanted, was both CMV and EBV naive. So we are watching that CMV, EBV, PCRs closely. CMV, you all know, Dr. Stark, you can help me out, the owl-shaped inclusion bodies or the immunohisto to make the diagnosis, but monitoring with the CMV PCRs. EBV uncontrolled because of the immunosuppression, the population, the CTLs that control the EBV infected cell not being effective could have expansion of either polyclonal or monoclonal and leads to PTLD. And that's a fairly common problem in pediatrics, unlike adults. About 10% or so, more common after primary infection. Degree of immunosuppression raises the risk. So somebody who got thymo or OKT3 as induction and had multiple rejection episodes would be at a higher risk. It could present just like mononucleosis or disseminated lympho or a tumor somewhere. What we do, we dial down the immunosuppression. We try to treat with the antiviral, but there is no good anti-EBV therapy yet. We have anti-CMV, but not so much for the EBV. When these measures don't fail, or sometimes even at presentation, monoclonal anti-CD20 is used. Very late presenting PTLD, which are more lymphoma-like, then we often involve oncologist colleagues and come up with a chemotherapy protocol. Unlike adults, these patients post-transplant, we have to be careful with the vaccines. They are still in the age group where they are expected to have various vaccines. We discourage live vaccines, measles, mumps, rubella, chickenpox, live flu, but we encourage killed vaccines, hepatitis A, B, flu vaccine in a timely fashion. This is just for Sunrise users where our protocols, policies, and presentations are you can find them if you want to go into details. There are nice order sets which we are constantly revising, looking at it as we go through each patient. The very first patient, we identified some opportunities, so we are again revising these and making them even more perfect. So thank you everybody to make this happen. Thank you for listening to me, but it gives me immense pleasure when I hold a kid he was doomed to die, and now you change the course. It really gives you goosebumps. Thank you. Questions?
Well, I have a comment. And the comment is really focused on this team. Of course, I thank you, Jennifer, and Glenn, and the entire transplant team that preceded me, because a lot of the work that was done in transitioning this program from St. Louis to University Hospital really happened before I arrived. And to get approval from UNOS and to get this program certified, by many people. So a lot of the good work was done. And then, the fact that everybody embraced getting educated and being prepared was, first we have to feel the transplant role and difference. And so, a lot of hard work was done by many, many people to get Victor successful outcome. As we all know, there's much more to be done.
Thank you.
I guess a question about biliary atresia.
Yes, sir.
Is there now a pre-screen test in the neonatal period where you can actually take a look at the child's bilirubin? I mean, is there a screening test now in the neonatal period?
So Dr. Becerra and Dr. Karamak, two leading uh, researchers in the field. And so they have that, I think, dream. And the Cincinnati group came up with the jaundice chip, but still falls short of listing biliary atresia in that jaundice chip. The current understanding has evolved from totally unknown to now we think maybe there are a unknown virus for the perinatal type in third trimester in a kid who has some T cell regulator problem. And yes, when they're born, you can look for that T cell regulation problem. So Karamak goes with that hypothesis. Dr. Becerra goes with more infectious disease, and maybe it is combination of two things together in an unlucky child. Because you can see this thing happening and still not have biliary atresia. You can see this thing happening, T cell regulation problem. You can identify, but over time, it is supposed to mature. So it's a maturity problem. So it's not one-time test you do and you say, here you have T cell regulation problem, you will develop biliary atresia. So I don't believe yet there is a good test out there. But yes, globally, not in USA, like in United Kingdom, Thailand, etc., biliary atresia being identified as a health problem. So they do send patients and moms home with some kind of scale showing color of the stools, that okay, if this is the color, call us right away. Or in UK, you are discharged at 2 weeks, you will get total bilirubin and direct bilirubin to early identify patient. In USA, when we discharge a patient, the first clinic visit is often at 1 month of age. Correct me, Jay, if that's not the case. And total bilirubin, direct bilirubin is not in the list of mandated workup at that time. So we still see a lot of problems in late identification. Actually, the group from St. Louis looked at 3 different time eras, 5-year period, 95 to 2000, 2000 to 2005, and then 2005 to 2010. And we are getting worse in terms of identification, despite all the resources we have.
How important is nutrition preoperatively?
Oh, that's the only thing I can do with the help of my dietitian. So it's very important. The way Peter Whittington used to say, that is the only thing you can change that will change your post-operative course. Because if you have strong muscles, you will be not on ventilator for long. You will come off easily. You will not develop all this complication in ICU sitting on ventilator.
So with that, then when do you feel is the most appropriate time, to transplant a patient with biliary atresia, who has a failed Kasai, is maybe 4 months of age, and you know that the Kasai is not working? What are the things that you're looking at in regards to at the point where how to transplant?
So our decision making for biliary atresia is very much shaped by a consortium group study, Biliary Atresia Research Consortium, BARC. In 2006, they came up with their paper where they pooled all the data from 10 different centers. And 2 prognostic factors emerged. One, total bilirubin 3 months after biliary atresia surgery. So if that is above 6, almost always you will need liver transplant by age 2. Second was the failure to thrive. So if you have 3 months later, it's still not thriving well, then again, you are going to need this. So those, everything else seemed to kind of give some prognostication. So one episode of cholangitis was actually surprisingly a better prognostic indicator. And 2, cholangitis suddenly changes the outcome. One cholangitis episode they thought is a measure or a marker of success of the flow. So that what shapes us, and that what shaped us our exceptional criteria point in our region. When I was in Dallas, talked with Saul Carpen, talked with Dr. Washburn here, and together we thought that we need to have exceptional points for those biliary atresia kids who meet those bad prognostic criteria.
Usually you can get a child up to almost 1 year of age, as long as they're continuing to gain weight.
Right.
Because, again, prognostically, the older you can get these children,
Better you are.
and the greater weight gain that you can have, the outcome is better. So it's this kind of risk-benefit ratio as to
Right.
exactly at what time you really press forward.
So we just keep monitoring, and if they are gaining, we are okay. The moment they start to plateau out, then we know this is the time. We can't, the window is closing on us. Or they develop ascites. Very rarely I've seen a kid who developed ascites turned around. A very rare kid where the nutritional deficiency was the cause of a low albumin and ascites, and you gave better nutrition and they turned around. One case I remember. But almost always when they develop ascites, the clock is, done.
I would think that makes so challenging for us to manage those children because so many of them are busy. So we've seen kids that were balancing that weight. They live in El Paso. You're deciding what to do, then you bring them down here and hit them, and in 2 weeks they gain weight.
What's the time?
It is like really challenging. But when, kind of based on your answer to that, when do you really start to seriously consider living donation as opposed to a trial on the list and gain those exception points for a kid like that with biliary atresia?
So I trained in a program where living donation was very common. When I was in Chicago, we were doing about half of our cases. It was 94 to 96. We were doing about 50 to 70 livers per year. I remember being on call on a Thanksgiving, and there were 11 pediatric liver transplants done in 4 days. Different game plan. And Dr. Brolsch was the surgeon who started the liver transplant, living-related transplant program there. By the time I became a fellow, it was Dr. T, Dr. Piper, Dr. Imond, who moved to, and they all were very strong in terms of living-related, pushing it forward. And my mentor, Dr. Peter Whittington, was also pushing that. So we were not waiting for that final situation where it is the 11th hour and then to offer. I recall kids where a school teacher wanted to donate and it was done. So it was a different game plan over there. Moving to Miami, I would say we rarely, very rarely did living-related. Just we did not have so much getting a graft as an issue there. It was a very big program, and there was not much competition for the state of Florida. So I recall only 1 or 2 kids in 5 years where we ended up doing. So it changed my view that yes, if a cadaveric liver is available, why subject the family member to another risk? And meanwhile, I think there were these reports of donor deaths that also were shaping our views. So I'm comfortable with what our surgeons have come up with our approach here.
To have an active split liver program, living donation is not usually necessary for children because of the priority they get in terms of allocation. And there's some technical advantages to doing split as opposed to a living donor split. That's great. Thank you.
Thank you.